First of all, we will discuss embryology, then we will discuss anatomy. So the foregut gives rise to the GI tract from esophagus down to the duodenum at the ampulla of water. Okay, so this is esophagus, this is stomach, then duodenum where the ampulla of water is open. So these parts develop from the foregut, and the foregut is supplied by the celiac trunk. Okay, foregut is supplied by the celiac trunk. Now, midgut extends from lower duodenum to the proximal 2/3 of the transverse colon. Okay, so now this is the duodenum. Then we are having jejunum. Then we are having ileum. Okay, I am drawing a rough diagram of this. And then there is ascending colon, then transverse colon. So 2/3 of the transverse colon up to there. This is developed from the midgut. Okay. Now midgut is supplied by SMA, superior mesenteric artery. Okay, the hindgut extends from distal 1/3 of the transverse colon to the anal canal above the pectinate line. Okay, so hindgut is developing rest of the GIT from the second, third part to the pectinate lines in the anal canal, and the hindgut is supplied by inferior mesenteric artery. Okay, so now we can summarize this. Foregut, esophagus up to ampulla of water opening duodenal part. Foregut is supplied by celiac trunk. Then midgut, so midgut is the last part of the duodenum to the second, third part of 2/3 part of the transverse colon. It is supplied by superior mesenteric artery. Then hindgut, so rest of the GIT up to anal canal above the pectinate line is developing from the hindgut, and it is supplied by inferior mesenteric artery. Now stomach rotate 90-degree clockwise during 4 to 6 weeks. Okay, at first stomach develop like this, then there is a rotation, clockwise rotation 90-degree, and stomach rotation position the left vagus nerve anteriorly and right vagus nerve posteriorly. Okay, so vagus nerve, left vagus nerve is anterior and the right vagus nerve is posterior. Now physiologic herniation of the midgut occur around the 6th week through the umbilical ring. Okay, so this is the physiological herniation, and then the midgut return to the abdominal cavity around 10th week. Okay, so at 6th week this herniation happen, and at 10th week then this herniation goes inside the abdomen, completing a 270-degree counterclockwise rotation around the SMA. Okay, so there is 270-degree anti-clockwise rotation. Now the midgut and yolk sac are connected via vitelline duct, which is omphallomesenteric duct. Okay, midgut and yolk sac are connected via the vitelline duct. Now what is omphalocoele? So omphalocoele is the herniation of abdominal contents through the umbilical ring. Okay, there is a membrane that are covering these abdominal content. Okay, peritoneal membrane is covering these content, but it is associated with Down syndrome and other congenital anomalies. Okay, and omphalocoele is covered by peritoneum and amnion, a shiny sac. Omphalocoele is associated with congenital anomalies such as trisomy 13, 18, Beckwith-Wiedemann syndrome. Okay, so omphalocoele is associated with these congenital anomalies. Then gastroschisis is para-umbilical herniation of the abdominal content through an abdominal wall defect. Okay, so this is our abdomen. Then these contents goes out. Okay, there is no covering membrane. Gastroschisis is not covered by peritoneum or amnion and is usually right-sided. The most common type of tracheoesophageal anomaly is esophageal atresia with a distal tracheoesophageal fistula, 85%. Okay. Now, esophageal atresia with distal tracheoesophageal fistula present with prominent gastric bubble on chest X-ray due to air entry via the fistula. Now, this is the esophagus. Okay, so there is esophageal atresia. Now I am drawing the trachea. So this is trachea then divide into bronchi, left and right bronchi. Okay, so this distal esophagus is connected to this trachea. Whenever a person breathes, so air goes through this and it goes into the stomach, and there is gastric bubble on X-ray. Okay, now pure esophageal atresia or stenosis present with a glasses abdomen on chest X-ray. Okay, gasless abdomen on chest X-ray. If there is pure atresia, so there will be gasless abdomen. Okay, now esophageal anomaly are associated with vectoral defect. Okay, hypertrophic pyloric stenosis is most common cause of gastric outlet obstruction in infant. So hypertrophic pyloric stenosis, it is the most common cause of gastric outlet obstruction in infant. What happened? That this is the stomach, so there is obstruction, and hypertrophy of pylorus occur as a result. There is obstruction. Now, pyloric stenosis present as postprandial non-bilious projectile vomiting and palpable olive-shaped mass in the epigastrium. Okay, so if there is blockage, okay, so these content will be expelled from the body by mouth. Okay, and there will be no bile because bile is secreted in this place. So, and there will be on abdominal palpation, there will be olive-shaped mass. Okay, now pyloric stenosis result in hypokalemic, hypochloremic metabolic alkalosis. What is present in the stomach? In the stomach there is HCl. Okay, so when HCl is secreted, so along with the vomit, this HCl will also be expelled from the body. As a result, loss of acid will lead to alkalosis. Okay, and chlorine is also so hypochloremic metabolic alkalosis. Now, duodenal atresia is due to failure of lumen to recanalize from solid cord stage. Okay, so this is solid cord, there is no recanalization. So this lead to duodenal atresia, and there will be double bubble sign on X-ray, and is commonly seen with Down syndrome. Okay, so these were all about anatomy, embryology. Now, gastrointestinal anatomy and histology. So retroperitoneal structure are posterior to and outside of the peritoneal cavity. Okay, now there is a structure. Let's suppose this is something. Okay, so it is enclosed by epithelium, by peritoneum, on the both surface. So this is surface will be known as intraperitoneal. Okay, if there is peritoneum just on the front, so then this is known as retroperitoneum. Okay, now the mnemonic for retroperitoneal, falciform ligament. So falciform ligament connect liver to the anterior abdominal wall. This is the liver, so this is connected to the anterior abdominal wall by the falciform ligament, and falciform ligament contain ligamentum teres hepatis, which is the remnant of fetal umbilical vein. So they may be asked like this, state what is the remnant of fetal umbilical vein? So it is ligamentum teres hepatis. Now, falciform and hepatoduodenal ligaments are derivatives of ventral mesentery. Okay, anterior mesentery. Hepatoduodenal ligament connect liver to the duodenum, as its name indicate, and the hepatoduodenum ligament contain portal triad. This is important. Okay, and hepatoduodenal ligament, there is portal triad. There are three things in the portal triad: proper hepatic artery, portal vein, and common bile duct. Okay, proper hepatic artery, portal vein, common bile duct. I repeat, proper hepatic artery, portal vein, common bile duct. These are the portal triad. The Pringle maneuvers involve compressing the hepatoduodenal ligament to control hepatic inflow bleeding. Whenever there is surgery performing and there is risk of bleeding or there is bleeding, so we do Pringle maneuver, in which we compress the hepatoduodenal ligament, in which there is hepatic artery, proper portal vein, and common bile duct. So there is the bleeding is stopped because there are bleeding due to these vessels. Now, the hepatogastric ligament connect liver to lesser curvature of the stomach and contain gastric vessels. So hepatogastric ligament, as its name indicate, liver to stomach. But which part of stomach? Lesser curvature of the stomach. Okay, if we look, so this is hepatogastric ligament. Lesser curvature of the stomach is connected to the liver by hepatogastric ligament. Now, gastrosplenic ligament connect greater curvature of the stomach and spleen, and gastrosplenic ligament contains short gastric and left gastroepiploic vessels. Okay, so the short gastric vessels is connected by the gastrosplenic ligament contains short gastric vessel and left gastroepiploic artery. Now, short gastric curvature, lesser curvature of the stomach is connected to the liver, greater curvature of the stomach is connected to the stomach. Now, splenorenal ligament. Okay, so splenorenal ligament connect spleen to the left pararenal space. Okay, as its name indicate, splenorenal ligament contains splenic artery and vein and tail of the pancreas. Now, the layer of the gut wall from inside to outside follow the mnemonic MSMS: mucosa, submucosa, muscularis, and then serosa or adventitia. Okay. Now, if it is erosion, so erosion are limited to mucosa layer only. Ulcer extend into the submucosa. The submucosa contains submucosal nerve plexus, which is known as Meissner plexus, okay, which primarily regulate fluid secretion. The muscularis externa contain myenteric. So it is myenteric nerve plexus, which is known as arbor plexus, and it regulates gut motility. Okay, so this is present in the muscularis externa. Now the frequency of basal electrical rhythm, slow wave, is highest in the duodenum. Okay, duodenum is higher than ileum, which is higher than stomach. Okay, so the frequency of basal electrical rhythm is highest in the duodenum. Now, the esophageal epithelium is non-catheterized stratified squamous epithelium. But what happened in Barrett esophagus? Okay, Barrett esophagus is a condition in which there is metaplasia of the esophagus due to exposure to the gastric acid, and this lead to conversion of the non-keratinized stratified epithelium into simple columnar epithelium with goblet cells. Okay. Now, the upper 1/3 of the esophagus contains striated muscles, skeletal muscle. The lower 2/3 of esophagus contain smooth muscles. Now, parietal cells in the stomach are eosinophilic, okay, pink, and secrete HCl and intrinsic factor. This is important, okay. If you are going to memorize just one thing of the cells, like parietal cells, cheap cells, all these, so parietal cell is important. It secrete HCl and intrinsic factor. Now, cheap cell in the stomach are basophilic and it secrete pepsinogen, okay, which is then converted into pepsin and then breakdown for the protein, okay, used for the breakdown of protein. Now, the duodenum is characterized by Brunner glands in the submucosa, which secrete bicarb to protect against stomach acid. Okay, so now this is the stomach. So in stomach there is acidity. So when the kind goes to duodenum, so there must be some protective mechanism. So there are Brunner glands that secrete bicarbonate and that neutralize that acid that is coming from the stomach. Now, Kyaneth cells are found in the crypts of Leberkuhn and secrete antimicrobial agent like defensins and lysozyme. The jejunum has the tallest and most prominent plica circularis and villi. Okay, the ileum is characterized by large lymphoid aggregates called Peyer's patches in the lamina propria and submucosa. So this is important. Peyer's patches are present in the ileum. Okay. Now, goblet cells, mucus secreting cells, are most numerous in colon. And colon contain crypts of Leberkuhn and abundant goblet cell, but it has no villi. Okay, what was the function of crypt of Leberkuhn? So these secrete defensin and antimicrobial activity. Okay, lysozyme. Now, spleen arise from the mesentery of the stomach. Okay, so it is mesodermal origin, dorsal mesogastrium, thus mesodermal, but its blood supply is from the foregut, celiac trunk. Now, what is annular pancreas? Okay, so annular pancreas is due to abnormal rotation of the ventral pancreatic bud, causing a ring of tissue around the second part of the duodenum. Okay, so now this is the duodenum. Okay, now pancreas develop like this. Okay, so what happened in annular pancreas? In annular pancreas, there is the ventral part develop and it form a ring-like structure around the duodenum. Okay, by the completion of the pregnancy, these two fuse together and form a pancreas. But here it's around the duodenum and it leads to duodenal obstruction also. Okay, so it is causing a ring of tissue around the second part of the duodenum. Now, what is pancreas division? So it is the failure of ventral and dorsal part of the pancreas to fuse at 7th week. Okay, so there are two parts. One is ventral part and another is dorsal part. So these two fuse then, but there is failure. So this is known as division pancreas. Ventral pancreatic bud contribute to uncinate process and pancreatic head. Okay, so like this is the pancreas. So this head and uncinate process is contributed by the ventral bud. Okay, now celiac artery. So celiac artery, as we have already discussed, celiac artery supply which part? Celiac artery supply foregut. Superior mesenteric artery supply midgut. Inferior mesenteric artery supply hindgut. Okay, so celiac artery branches into common hepatic, splenic, and left gastric artery. Okay, now arteries supplying gastrointestinal structures are single and branch anteriorly. So GI parasympathetic innervation for the foregut and midgut is provided by the vagus nerve. Okay, while the hindgut, so it is pelvic splanchnic nerve. Okay, now the parasympathetic innervation of foregut act at vertebral level T12 to L1. The parasympathetic innervation of the midgut acts at the vertebral L1. So T12, L1, L1. Now parasympathetic innervation of the hindgut acts as L3. Sympathetic innervation arises from the abdominal prevertebral ganglia, celiac, SMA, IMA. Watershed areas are the part of the colon with dual but distal blood supply, making them susceptible to ischemia. Okay, so this is the colon, this is the splenic flexure. So this is most vulnerable for ischemia, and this is watershed area. Okay, and it is susceptible for the ischemia or infarction. Okay, now primary watershed area is the splenic flexure supplied by SMA and IMA branches. Okay, now second watershed area is rectosigmoid junction supplied by IMA branches and superior rectal artery. Okay, so rectal and sigmoid colon and rectum junction. Okay, so this is the second watershed area. Now nutcracker syndrome is compression of the left renal vein between SMA and the aorta. Okay, so as we know that this is vena cava, so vein are draining here into the aorta. So there these vein compresses in the aorta and superior mesenteric artery. This leads to nutcracker syndrome, and it can cause grass hematuria and left-sided varicocele. Why it is causing varicocele? Because left testicular artery is draining, left testicular vein is draining into the left renal vein. Okay, so that's why. Now superior mesenteric artery syndrome is the compression of the transverse third portion of the duodenum by superior mesenteric artery and aorta. SMA syndrome is associated with conditions that diminish mesenteric pad, such as rapid weight loss. In portal hypertension, blood shunt through three main sites of anastomosis. What are these sites? Esophagus. Okay, so in esophagus it gives esophageal varices. In umbilicus it gives caput medusae, and in rectum it gives hemorrhoids. Okay. Now, esophageal varices form from the anastomosis between left gastric vein portal and esophageal vein systemic draining to azygous vein. Caput medusae so forms from anastomosis between paraumbilical vein and the small epigastric vein. Then anorectal varices form from anastomosis between superior rectal vein and the middle inferior rectal vein. Now, congenital and acquired GI defects. Okay, so TIPS, transjugular intrahepatic portosystemic shunt, connect portal vein and hepatic vein to bypass liver and relieve portal hypertension. Okay, so now this is the portal vein. It goes into the liver. If there is liver cirrhosis or something like that, so then the blood is not draining, so there is hypertension developed. So there is a procedure which is known as TIPS. So it connects the hepatic vein directly to the portal vein, and then it is draining by itself. Okay, but there are no detoxification of substances and metabolism in all this. TIPS can precipitate hepatic encephalopathy due to shunting of ammonia fast the liver. Okay, why? Because ammonia metabolism is occurring in the liver. Okay, now the pectinate dentate line is where the endoderm hind meet the ectoderm. Okay, it is the point in which the endoderm meet the ectoderm. Now, internal hemorrhoid occur above the pectinate line and are typically painless, while external hemorrhoid occur below the pectinate line and they are painful. Okay, now, Meckel diverticulum is the most common congenital anomaly of the GI tract, and Meckel diverticulum is a true diverticulum. It involves all the gut layer. Meckel diverticulum is the persistent remnant of vitelline amphilomesenteric duct, and the rule of twos for Meckel diverticulum. So this rule of twos include that this is present in 2% of population. This is 2 inches long, 2 feet from the ileocecal wall. And Meckel diverticulum may contain ectopic acid secreting gastric mucosa that can lead to bleeding. Okay, and pancreatic tissue also. Meckel scan. So this use 99 TC per technitate to detect uptake by heterotopic gastric mucosa. Zenker diverticulum. So the Zenker diverticulum is a pars diverticulum. There is only mucosa and submucosa outpouching. This is esophagus, so the mucosa and submucosa outpouch here. Okay, this is a pharyngoesophageal pars diverticulum. And Zenker diverticulum result from herniation at the Killian triangle. There is Killian triangle in the pharynx, a weakness in the inferior pharyngeal constrictor. Okay. Now diverticulosis. So diverticulosis involve multiple false diverticula of the colon, commonly the sigmoid, and diverticula are false mucosa, submucosa only because they occur where vasa recta penetrate the muscularis externa, creating a focal weakness. Diverticulitis is now inflammation of that diverticulum. Okay, and it causes left lower quadrant pain, fever, and leukocytosis. So if a middle-aged or old-age person presented to you with left lower quadrant pain, fever, leukocytosis, so common things are common, you will have to suspect diverticulitis. Now, Hirschsprung disease. So it is a congenital megacolon, big colon, characterized by lack of ganglion cell, Arbach and Meissner flexes in the distal colon. So if there is no Arbach or Meissner flexes, so there will be no relaxation. So this distal part, there is no neurons, okay, ganglion cells. So this distal part will become big. This is known as megacolon. This is due to failure of neural crest cell migration. Hirschsprung disease is associated with loss of function, mutations in the rat gene. Now, clinical signs include failure to pass meconium and empty rectum on digital rectal examination due to a ganglionic segment being narrow. Okay, so there will be empty rectum and it is present congenitally. Okay, now interoception is the telescoping, okay, of proximal bowel. Now, this is the bowel normally. Okay, so what happened that this part goes inside the distal part. Okay, so this proximal part goes inside the distal part, and this is known as telescoping of the bowel, and it is interoception, and it is most commonly seen at the ileocecal junction. Now, jejunal and ileal atresia, so it is typically caused by a disruption of the mesenteric vessel, small mesenteric, superior mesenteric artery, leading to ischemic necrosis of the fetal intestine. So, jejunal and ileal atresia is typically caused by disruption of these mesenteric vessels, and it lead to ischemic necrosis of the intestine. So that's all about anatomy.